So this is Cat, a female adult DSH with a body weight of 1.5 kilogram. With the cat body constitution score is 1.5 over 5, and the vaccination and deworming is unknown. The history is on 13 September 2021, Cat was found by a rescuer. Next day, the owner brought to a private vet, and Cat was presented with a lateral recumbency and myiasis infestation at the caudal ventral abdomen, and the skin tail was logging off. And Cat also have non-weight bearing lameness at the both hind limb. Cat was alert, responsive, with a good appetite, but did not defecate since the owner found her. The private vet prescribed metronidazole, Danzon, methylcobalamin, lactulose, food therapy was given. The wound at the caudal ventral The wound at the caudal ventricle was healed, but the lameness still persists. And Cat was referred to UVH for radiological examination. 2 weeks later, Cat was presented to UVH, and Cat had not defecate, and the intestine is full of feces. CBC and SBC was done, and there is marked neutrophilia with the left shift, monocytosis, eosinophilia, which indicating infection ongoing. Tramadol, Mabosy, Stanzil, and IV fluid was given, and retention enema was done. From that, a soft feces with the score 1 come out after the retention enema. Radiograph was done with the finding of left body of ilium fracture. And then Cat was discharged out on 15 October to be referred out for the manual evacuation. However, at the 18 October 2021, which is on this Monday, Cat returned to UVH for admit for colotomy. During physical examination on 18 October, Cat was bright, alert, responsive with the pale mucous membrane, CRT 2 seconds, and skin tan more than 2 seconds. The BCS is 1.5 over 5 and with the dehydration of 7%. Cat have distended abdomen, which is prominent at the left side where the descending colon was located, and it also has non-wet lameness at the both hind limb, but still have sensation and pain reception. And there is a presence of healing wound at the ventral perineum, and there is also wet fecal stain at the perineum area. So for the problem list, which is number 1, which is the non-weight bearing lameness, the differential diagnosis could be due to the pelvic fracture, could be due to the fracture of the pubis and ischium, or sacroiliac or fracture of the body of ilium. So the further plan is to do the pelvic radiograph and CBC and cerebral biochemistry. The second problem is which is the distended abdomen, could be due to the constipation, obstipation, or megacolon. And the plan is to do the abdominal radiograph. And the third problem list, which is the 7% dehydration, which could be due to the problem number 1. So the further plan is to give the IV fluid therapy. The CBC was done on 13 October. And then of that, there is presence of the leukocytosis with the marked neutrophilia with the regenerative left shift, and also monocytosis and eosinophilia, and the reticulocyte number is quite high, which indicating there is ongoing reticulocytosis. And for the serum biochemistry, there is a sign of azotemia. And then there also increase in total protein, which due to the hyperglobulinemia. And pre-op radiograph was done on 13 October with the however, we cannot retrieve the image, but the radiological findings during this pre-op radiograph is the fracture of the left body of ilium. So this is the updated problem list. For the non-wound bearing lameness, we rule out the fracture of the pubis and ischium and the sacroiliac laceration. And then for the further plan is to do the pelvic repair, which is after we do the colotomy. And then for distended abdomen, we still haven't ruled out the differential diagnosis because the abdominal radiograph haven't been done yet. But we plan to do the colotomy to remove all the feces inside the colon. And then for 7% dilation, we continue to give the IV fluid therapy. So for problem this for 7% dilation, we give lactated agar solution at the maintenance rate plus with the dehydration rate, which to correct the dehydration.
For anesthesia protocol, it was classified as ASA class 3 because she had 7% dehydration and also moderate systemic inflammation, as there is a leukocytosis based on the result. And the cat was pre-medicated with tramadol 5 mg per kg and midazolam 0.4 mg per kg, which are both given intravenously. And the cat was induced with propofol 5 mg per kg IV and maintained with isoflurane 2.5 to 1.5% with oxygen flow rate 0.2 liter per minute, and also given together with dopamine 6 mg per kg per minute CRI. However, it was changed to TIVA as a maintenance, and also dopamine was increased to 20 microgram per kg per minute CRI due to the hypotension kept persist during the intra-op. Next. And during intraoperative anesthesia, hypotension still occurs. So the intervention done was gilofuscin given 16 mg per kg IV as a colloid to increase blood pressure. And also dopamine that was given initially at 6 microgram per kg per minute and increased to 20 microgram per kg per minute CRI to maintain MAP above the 60 millimeter mercury. And also due to the hypotension did not resolve, so we changed to total intravenous anesthesia or TIVA, which is the combination of sedative, analgesia, and also muscle relaxant, which in this case we use tramadol 5 mg per kg and also midazolam 0.4 mg per kg per hour, and also intermittent positive pressure ventilation or IPPV by bagging the receiver board back not more than 10 millimeter mercury as a maintenance of anesthesia after isoflurane was stopped due to persistence of MAP less than 60 millimeter mercury. Okay, next.
So we proceed with the surgery, which is colotomy, that was done on 18th of October, this Monday, previous Monday. So surgical site is prepared from mid-chest until pubis, and the animal was placed on dorsal recumbency. And drip and outside was put on the surgical site. And then skin incision was made using scalpel blade number 20 from xiphoid to pubis. And the urinary bladder was located and exteriorized. And then cystosynthesis was done using 23 gauge butterfly catheter. And 100 ml of yellowish urine was aspirated out. And then descending colon was located and exteriorized. 2 stay sutures were placed 12 cm apart to hold the descending colon using ethylene 30. And 6 cm longitudinal incision was made on the colon surface using scalpel blade number 15. And then wet sterile gauzes was placed adjacent to the colon to prevent any spillage of fecal material into the abdominal cavity. And fecal material was removed using spun forceps, and any fecal material that was not reachable will be pushed towards the incision site to be removed. And then after removing all the fecal material, colon closure was done using simple interrupted suture pattern using Vicryl 30. And then leakage test was done by injecting warm normal saline into the colon lumen adjacent to the suture site. And the secondary simple interrupted suture were placed if there was leakage found. And after that, the abdominal lavage was done using 1 liter warm of saline, and saline is being sucked out using the vacuum suction machine. And then after that, OHE also was done in this case. And finally, routine skin closure was done where the muscle will close with simple continuous suture pattern using Vicryl 30. Subcut is closed with pushing suture pattern using Vicryl 30, and skin also was closed using intradermal suture pattern with Vicryl 30. So for post-op radiograph that were taken on 18th of October, which is immediately after the surgery, and also on the 21st of October, which is the day 3 post-op, we can see that the radiological finding, there is no hard fecal materials and no evidence of megacolon, where the ratio is 0.63, the ratio of colon diameter to L5 length. And then on VD view, we can see that there is also no presence of fecal material in the colon, and the fracture at the we can see also there was a fracture at the left body of ileum with a sacral index of 0.82. So we can approximate like 80% of pelvic narrowing happened in this case. So the plan was to do pelvic repair. And there was also CBC done on 21st of October, where the finding there is a leukocyte count increased to 70, and the indication was there is a leukomoid reaction in this case. So for post-operative management, for problem of post-colotomy and OHE, we fast the cat on day 1 to day 2 post surgery to rest the GIT function, and also we give IV fluid maintenance with G5 on day 1. This is to provide energy, and also to monitor the blood glucose from day 1 to day 8. This is to prevent any hypoglycemia. And for post-operative treatment for post-colotomy and OHA, we give amoxicillin 150 mg per kg subcut SID at day 1 post-surgery and day 3 post-surgery as broad-spectrum antibiotics. Metronidazole 50 mg per kg IV BID from day 1 to day 7 as anaerobic antibiotics. Lactulose 1 ml PO/BID from day 3 to day 8 as a stool softener. And also tramadol were given 3 mg per kg subcut TID from day 1 to day 8 as an analgesic. RC recovery liquid 10 ml TID from day 3 to day 8, and also RC recovery wet food, where 1 spoon will mix with 5 ml of water, SID from day 4 to day 8. This is for to provide nutrition and slow recovery of the GIT. And then ceftriaxone 25 mg per kg slow IV BID from day 3 to day 8 were given as an antibiotics. And then IV fluid therapy LRS as a maintenance and dehydration was given on day 1 to day 4 to correct dehydration and for maintenance. So the progression post-op from day 0 to day 5, the suture site is dry, clean, and intact, and the swelling of the suture site has been reduced. So the prognosis for this case is guarded because despite the cat seems to recover well, however, the recurrence of constipation can occur due to the narrowing of the pelvic canal due to the pelvic fracture. So the pelvic fracture need to be done before the constipation recur again in this case. That's all from us. Thank you. Any question?
Assalamualaikum. Can I see your problem list? Right. As you mentioned about this, the risk of recurrence of the constipations as a result of the pelvic canal stenosis, I think that should be reflected in your how you list your problems. Okay, for example, you put your problem number 2, distended abdomen. You just put your differential constipation, obstipation, megacolon, but you didn't mention how it related to the problem number 1. Okay, so this this constipations most likely because of this stenosis, secondary to this pelvic fracture. That should be reflected clearly in your problem list, so that when you manage this constipations concurrently or immediately, you also have to address the problems with the pelvic fracture that cause this the narrowing of the pelvic canal. Okay, and then as you mentioned about the importance of this pelvic canal stenosis, that means following the colotomy to remove the feces, to have to clearly mention about the needs of immediate pelvic fracture repair before the deficit start to build up again. Right. So that should be clearly mentioned in the plan. Thank you.
And just to add up, I think your problem number 3, 7% dehydration, due to problem number 1. So your problem number 1 is non-weight bearing lameness. How can non-weight bearing lameness cause 7% dehydration? I think probably you want to correct it, like add into your problem list whether the cat is actually inappetence that can lead to this 7% dehydration, and then you write that due to inappetence instead.
Okay, we'll make the correction to this. So there's a question which is why ceftriaxone antibiotic was given even though the amoxicillin and metronidazole was done. So cat was treated with the antibiotic prior to the surgery, which is even like 2 weeks before from the first admission at the private clinic. And then since that up to 13 wait, and then since then up to the 13 of October, we still see increase in leukocytosis. And then from the latest CBC, which is done on 21 October, there's still increase of leukocytosis, which up to 70, and this indication is reflecting the recombinant reaction is ongoing on. Okay, so it means that the previous antibiotic, which is the amoxicillin and metronidazole, is cannot clear the infection that been going on. Plus, this colotomy is a high is this colotomy can cause secondary infection to the abdominal cavity. So instead of waiting the leukocytosis from going worsen, so we give a potent antibiotic, which is the ceftriaxone, to hopefully to reduce this the leukocyte count.
Any better choice of suture materials to be used? to close the colotomy site. What is the suture material used to close the colon?
For colon closure, we use Vicryl T0, Doctor.
Any better choice of sutures? Do you know why we don't recommend Vicryl for this kind of surgery?
Is it because of there is possibility of Vicryl being disintegrate and then causing the leakage again, Doctor?
Why?
Hmm?
Why?
Because Vicryl is absorbable, so in case there is the wound is still not healing, but the suture is being absorbed, so the uh, so the incision site will be open again and can contaminate the whole abdominal.
So do you recommend a non-absorbable suture?
I
No, it's the fact that Vicryl is a multi-filament. Okay, always we use monofilament for dirty surgical procedures involving the viscous organs like intestines, urinary bladder. So we usually recommend monofilaments. You can suggest one example. Monofilament sutures.
PDS T0.
Yeah, PDS.
Sorry, Doctor.
Okay.
Actually, I typed it wrongly. Sorry. The correct suture material that we use is PDS T0 for this colon closure.
Why we don't recommend multifilament?
Multifilament, in case of this colon, the multifilament can attract the bacteria to be reside in between the multifilament, so can cause the build-up. I mean, not causing the build-up. I mean, it can trap the bacteria and then cause the infection towards the surrounding tissue. So instead of closing the suture, this trapped bacteria can cause inflammation on the surrounding tissue of the suture. Surrounding suture site, yeah. And then from that can prolong the recovery of the colon.
Okay, these sutures with a lot of the can harbor the bacteria within the interstices. When you drag it through the lumen of the colon and then you drag it out, then it will cause the conformation.
So
Okay, one thing about the you mentioned about this the next plan is to perform the pelvic fracture repair. How soon the pelvic fracture repair is planned for?
sorry, Doctor, can you repeat again?
You
How soon?
mentioned that the next plan is to perform the pelvic fracture repair.
Yes.
How soon it would be?
They said after cat getting more stable, and then after that then they start to do the pelvic fracture, but the exact exact time when we going to do is not sure yet. I think maybe probably in 2 weeks. Um, and then depends on the patient behavior also, and then from the progression of this surgery. If it's feel faster, and then we can start to do the pelvic repair.
Okay, one thing you can consider here is to tell how whether you can delay the next surgery in the pelvic fracture repair. If you can perform this rectal palpation. Okay, of course, from the radiograph, it show a very severe pelvic stenosis. But of course, the radiograph only can show not 3D dimensions of the size, the status of pelvic canal. The only one view. But probably when you do the rectal palpation, probably you can check that there's still a space, room for the fissure to pass through, probably dorsal to the distal bone fragments. So still possible to do put the cat on the negative, and then probably it's not a complete obstructions. But still surgery is still indicated to correct this pelvic stenosis, because the fact that the narrowing is quite severe. Okay?
So for Dr. Chen's question is, has CBC been repeated after the colotomy or change of the antibiotic? Yes, we repeat the CBC, and then since there is an increase in there is a sign of locomotor relation, we start to give ceftriaxone starting from yesterday. If there is no more question, can we proceed to the next case?
So we are going to present on a case of cystolithectomy in a domestic short hair cat. So Graph is a feline 2-year-old female domestic short hair fed with Hill's urinary diet and vaccination, and deworming status was not available. So for the history on 6th of September 2021, it has 3 episodes of hematuria and was hospitalized in the private clinic. It was treated with antibiotic, muscle relaxant, which is diazepam, and also with urinary SO diet. So on the 23rd of September, it was referred to UVH, and abdominal radiograph was done, revealing the presence of cystolyths. CBC, SBC, and also urinalysis revealed no significant findings, and it was scheduled for cystolithectomy on the 21st of October. So on 20th of October, it was admitted for surgery. So upon the physical examination, the TPI was within the normal limits. It was bright, alert, and responsive with pink mucous membrane, CRT less than 2 seconds, and skin tan less than 2 seconds. There was palpable stone in the bladder, and no hematuria was noted. So for the problem list, the first problem list will be the hematuria from the history, and also the second problem list will be the palpable stones in the bladder. And we came up with the differential diagnosis of urolith, either struvite or calcium oxalate, and bacterial cystitis and feline idiopathic cystitis. So the plan was to do CBC and SBC to evaluate the renal parameters, and also if there's any other health issues, and abdominal radiograph to evaluate the location, size, and number of stones that is available in the urinary tract, and abdominal ultrasound was to evaluate the kidney and also the bladder wall, and cystolithectomy was suggested. So for the urine analysis, the urine was collected through cystocentesis and it was pale yellow with a specific gravity of 1.025, which is minimal concentration ability, and it was 2+ for the turbidity. So for the chemically, it was pH 6 and the others was within the normal range. And for the microscopic, there was 5 to 10 erythrocytes and there was 10 to 15 leukocytes, suggesting that maybe there could be any inflammation on the lower urinary tract, and epithelial cells of the squamous cells was 1 positive, renal cells was 1 positive, 1+, and there was coarse granular cast and calcium carbonate and fat droplets.
Next, for the CBC and the serum biochemistry, there was non-significant finding for the hemogram. Next, but for the leukrogram, there was lymphopenia on the 20th of October. Next, for the serum biochemistry, there was high normal in sodium, urea, and total protein, which indicate hemo concentration. Next. For the radiograph, a right lateral abdominal radiograph was taken on the 23rd of September and reveals the presence of multiple radio-opaque irregular surface of stones in the urinary bladder with stone size ranging from 0.34 to 0.61 centimeters. So we come up with the radiographic diagnosis of cystolithiasis. Similar finding was found on the ventrodorsal view. A day prior to surgery, the abdominal radiograph was repeated and similar finding was found, which is the presence of radio-opaque irregular surface of stones in the urinary bladder with stone size ranging from 0.39 to 0.55 centimeter, indicating cystolithiasis. Similar finding on the ventrodorsal view. So ultrasound was done on the 23rd of September. And for the urinary bladder, there was presence of hyperechoic irregular structures in the urinary bladder, indicating cystolithiasis. For the right kidney, the size was still within the normal range, but there was mild irregular renal cortex with slight indistinct cortico-medullary junction. Similar finding on the left side. So for the updated problem list, we rule out bacterial cystitis and feline idiopathic cystitis based on clinical signs, CBC, and abdominal ultrasound. Next. So we come up with a tentative diagnosis of cystolithiasis. So for the pre-op treatment of hematuria and cystolithiasis, graft was treated with amoxicillin 10 mg per kg, 0.2 ml subcut each other day as a broad-spectrum antibiotic, Cystat 1-tab POSID as bladder supplement, fluid therapy with LRS as a maintenance fluid. So a cystolithectomy procedure was scheduled on the 21st of October.
For anesthetic protocol, graft was classified under SA class 2 because there is no systemic inflammation or infection. And then we pre-met with tramadol 3 mg per kg subcutaneous, midazolam 0.4 mg per kg IV. And then we induced with propofol 5 mg per kg IV and maintain with isoflurane 0.8 to 1.5% and also propofol 6 mg per kg given 1.2 ml intravenously. And then during intraoperatively, there is a incidence of hypotension. So we manage by giving gelofuscin 1 ml per kilogram with maximum dose of 20 ml per kilogram per day, given 25 ml bolus IV, and also dopamine 12 microgram per kilogram per hour CRI. And then we did local block, which is the lidocaine 1 ml subcutaneous at the surgical site.
So moving on to the procedure, OHA was done before proceeding to the cystolithectomy as an elective surgery. So for the surgical procedure, first, the skin incision was made 2/3 away from the umbilicus with blade number 20. And then subcutaneous layer was undermined using the Metzenbaum scissor. And a step incision using blade number 15 was made on the linea alba and further extend with Metzenbaum scissor. Then the urinary bladder was isolated and packed with moisture gauze, and two-stage suture was placed at the apex of the bladder by using PDS 30. A longitudinal incision was made at the dorsal aspect of the bladder. Urine was removed using a 10 ml syringe before the removal of cystolith using curette. After removing the 5 cystolith in the bladder, retrograde urohydrocorpustion was done by administering the sterile saline through the urinary catheter. And then sample was taken from the bladder wall with sterile swab and sent to bacterial lab. And the bladder was closed with simple continuous suture pattern using PDS 30. After the closure, leakage test was done and the incision site was reinforced with simple interrupted suture on site that was leaking. And abdominal flushing was done using sterile saline to avoid peritonitis before closing the abdomen. And omentum was placed on top of the bladder to promote healing. Prior to closure, the surgical set was changed to maintain aseptic field and the abdominal was flushed once again. So muscle layer was closed using simple continuous suture pattern. Subcutaneous layer was closed using modified Cushing suture pattern, and skin was closed using intradermal suture pattern. All of the layer were closed using Vicryl 30. 5 cystolith was removed and the size of the stone was similar to the size measured in the radiograph. For the post-op radiograph, there was no stone found in the urinary bladder. The bladder wall swab was taken and sent to the bacterial culture, sent for bacterial culture and ST, and the result is still pending. The final diagnosis for this case is cystolithiasis. For the treatment plan, problem number 1, post-cystotomy, we give amoxicillin 10 mg per kg each other day subcutaneously for day 1 to day 7 as broad-spectrum antibiotics. And then cystate 1 tab SID was given on day 1 to day 7 as bladder supplement, and fluid therapy LRS was given on day 1 to day 5 as maintenance fluid. Tramadol 3 mg per kg was given subcutaneously on day 2 to day 7 as analgesic, and diazepam 0.5 mg per kg was given on day 3 to day 7 as muscle relaxant. The prognosis for this case is good because of smooth recovery and Graf was able to urinate on her own without catheterization. For the client education, owner must understand that this surgical intervention is just temporary solution for the problem. So the management and owner compliance is crucial in this matter to prevent the recurrence. So owner should be informed that there might be mild hematuria for 3 to 5 days post-operatively. And for the management, first graft should be maintained on urinary diet to prevent formation of stone, provide unlimited amount of clean water, monitor urination and take note if there's any abnormalities such as hematuria, stranguria, and pollakiuria, and then provide adequate litter box and reassess every 3 to 6 months. So that's all from this case.
Any questions? If not, we proceed to the next case.
When you mention about reassessment every 3 to 6 months, what do you expect to look for? What will you do when the cat come back for reassessment?
So for the reassessment, we will do urinalysis and do crystal analysis to see if there's any recurrence of this cystolithiasis recurrence.
In this case, what's the urine's pH?
The pH was 6, doctor.
Yeah. So what is your advice to owner about the management of this cat after this?
We would suggest the owner to maintain the cat on urine diet.
Is that all?
Besides the urinary diet, encourage drinking by provide unlimited amount of clean water and then provide adequate litter box.
Okay, normally, besides saying it's urinary diet, you also have to see whether most likely what do you think is this stone, because you are not sending for analysis to find out what kind of stone they are. So there are different kind of products out there. There are something is for screw white, some is for calcium oxalate and screw white, things like that. So you have to be more specific than saying urinary diet, because the client will ask you which one should they take and how long should they take. And for the water intake, I'm sure the owner has already put water in the house. So to encourage the cat to drink more water is not like putting more little tray by putting more bowls at home. Cat will only drink when they are thirsty, when they want to drink. Putting more bowl, I don't think will further encourage them to drink more. But having water fountain seems to work well for some animals because they like water fountain and then they tend to drink more. And then besides that is to offer like wet food because wet food has high water content. So, and some they might add a bit of water or like tuna juices in the diet to encourage more water intake. But when you offer wet food, you have to tell owner that in terms of oral health, dry food is better than wet food. So when they have wet food, probably they will have more tartar build up at a faster rate. So it's something that they need to tackle, like cleaning, find some way to clean the teeth and things like that.
Okay, thank you, doctor. And to add on the diet, we have come across that Hills CD, it can be given long term and it can be used to treat very different sources such as Truvite, calcium oxalate, and FIC. Whereas SD from Royal Canin, it should be given short term and treat Truvite only.
Okay, thank you. I think SD is from Hills. SO is from Royal Canin.
Okay, doctor. Thank you.
So next, we would like to present case of caudectomy and perineal resection in Siberian Husky. So this is Rocky, 6-year-old male Siberian Husky with body weight of 19.8 kilogram and BCS of 3 out of 5. So he is managed as an outdoor dog with other 4 dogs, and the vaccination and deworming status was not stated. So the history was on October 2020, the owner noticed ulcerated mass at the base of the tail with size of 3 times 4 centimeter, and he went to private vet but no improvement. So in September 2021, they stopped visiting private vet and treated Rocky themselves, and the mass is getting bigger with size of 6 times 6 centimeter. So on October 2021, he was referred to UBH. So the physical examination finding was the TPR were within normal range. He was bright, alert, and responsive with pink mucous membrane with CRT less than 2 seconds and skin tan less than 2 seconds. So there was presence of 6 times 6 centimeter ulcerated mass at the base of the tail, and also presence of 2 times 2 centimeter ulcerated mass at the perianal region, which dorsal to the anus, and also presence of 1 times 1 centimeter ulcerated mass at the right forepores. And then there was also presence of 1 times 1 centimeter non-ulcerated mass at the left forepore and 2 times 2 centimeter non-ulcerated mass at the left forepore. So this is the picture of the mass at the right forepore, and on the right we can see the non-ulcerated mass at the left forepore. This is a picture of the mass at the perianal region, which dorsal to the anus, and the picture on the right shows the ulcerated mass at the base of the tail. So we come out with the problem list of presence of mass with size of 6 times 6 centimeter at the base of the tail, and also 2 times 2 centimeter ulcerated mass at the perianal region, which dorsal to the anus. We come out with the differential diagnosis of neoplasia, abscess, and granuloma. So for the neoplasia, the differential will be the perianal adenoma or hepatoadenoma, and so squamous cell carcinoma and mast cell tumor. So for the mass, 1 times 1 centimeter ulcerated mass at the right forepore and 1 times 1 centimeter non-ulcerated mass at the left forepore, and the 2 times 2 centimeter non-ulcerated mass at the left forepore, we come up with the differential of neoplasia, abscess, granuloma, and cyst. And for the neoplasia, the differential will be histiocytoma, squamous cell carcinoma, and also mast cell tumor. So the further plan was to do CBC and serum biochemistry, thoracic radiograph, pelvic radiograph, impression smear, FNA and cytology, biopsy, and also surgical resection and caudectomy. So the radiograph was done on the October 2021. So the finding was presence of soft tissue opacity at the base of the tail with no bone changes. So the radiological diagnosis will be the tail mass. So the thoracic radiograph was done for MET check, and there was no significant finding. For CBC and serum biochemistry, the CBC results show microcytic hypochromic regenerative anemia and also eosinophilia and reticulocytosis. And for serum biochemistry, there are low urea and also slight hyperglobulinemia to be due to infection or inflammation. So impression smear on the tail of the tail mass was done, and the results show abundance of intact and degenerated neutrophils and also free and phagocytous bacteria, which indicate infection and inflammation. So procedure caudectomy, castration, and perianal mass resection was done yesterday, which is on 21st of October.
For the anesthetic protocol, this dog was classified as ASA class 3, and we pre-med with morphine 0.5 mg per kg given 1 ml IM, induced with propofol 5 mg per kg given 10 ml IV, and was maintained using isoflurane 2% and oxygen flow rate 1 liter per minute. And before the surgery, we also perform epidural block using bupivacaine 0.2 mg per kg and morphine 0.1 mg per kg. We also do intratesticular block using bupivacaine 0.2 mg per kg given for meal. And for the post-op, we give meloxicam 0.2 mg per kg given 0.8 ml subcut.
Next, we will move on to the surgical protocol, which is the caudectomy. And the pre-scotus castration were done prior to the caudectomy. So firstly, the entire perineum and tail head area were clipped and aseptically prepared, and the animal was placed in ventral recumbency like in this picture. And the sterile coban were wrapped around the whole tail in aseptic technique to ease the tail manipulation. And the drape were placed in a way that the tail and the perianal mass were exposed. And elliptical incisions were made at the dorsal part of the tail proximal to the mass location. And the tail were lifted up, and the same elliptical incisions were made at the ventral part of the tail so that it continuing the previous incision that were made on the dorsal part. Next, monopolar blade were used to bluntly dissect the subcutaneous muscle. And any bleeding were controlled by bipolar electrocautery. And next, several ligatures were also made using absorbable PS30 suture to prevent any excessive bleeding. The muscles were then continued being dissected using monopolar blade to expose and locate the caudal vertebrae or the coccygeal bone. The tail were then transected using bone cutter at the proposed region of second or third caudal vertebrae. Any bleeding were controlled by applying pressure with sterile gauze or by using ligature using absorbable PDS30 or by using bipolar electrocautery. When we are sure that hemostasis is achieved and there is no more bleeding, the site were then lavaged. The subcutaneous tissue were then closed using absorbable PDS30 with cushion suture pattern, and the skin were closed using Restylane monofilament 20 with cruciate pattern. This is how the cruciate suture pattern that were done on the skin. Next, we'll proceed with the lumpectomy mass at the base of the tail. First, a round incision were made approximately 1 cm around the mass using scalpel bit number 15, and the subcutaneous tissue were then bluntly dissected using monopolar blade. And then the mass were removed. Routine skin closure were done. At the end of the surgery, we also did incisional biopsy of the mass that are located at the left paw. So all the excised masses during the surgery were then sent to the histopathology lab for identification, and the result is still pending. These are the treatment for post-caudectomy and perianal mass resection. We give amoxicillin clavulanic acid 17 mg per kg half tab per oz BID on day 0 onwards as prophylactic broad-spectrum antibiotics. Metronidazole 15 mg per kg 60 ml slow IV BID day 0 onwards as antibiotics against anaerobes. We also give Pepis 1 tab BID day 1 to day 4 as anti-inflammatory to treat inflammatory reaction. And meloxicam 0.1 mg per kg, 0.4 ml subcutaneously as ID were given from day 1 to day 3 as an NSAID to relieve pain and inflammation. Other than that, Vaseline and chloramphenicol ointment were applied at the surgical site day 1 onwards as topical antibiotic. And also IV fluid therapy, which is a solution, were given as maintenance fluid. Other than that, we also gave B-complex 1 tab BID per oz day 1 to day 2 as multivitamin and to increase competence. And ranitidine 2 mg per kg IVTID were given from day 1 to day 2 to prevent stomach ulcer. For the problem of regenerative anemia, we gave parasite 1 tab SID per oz day 1 to day 2 as iron supplement. So for the prognosis of this case, we think it is fair because we found out that we did not get a very good margin of the resected mass at the base of the tail, and the possibility of it to recur over there. And now we will have to wait for the biopsy result to really find out what is the mass. And if the result came out to be benign perianal adenoma, we were hoping that by doing castration, the lack of a tumor would regress by its own. As for the client education, we have to monitor the suture site daily for any suture breakdown or any bleeding, and make sure the surgical site is clean from any pieces to avoid contamination and bacterial infection. And then the animals have to wear a collar to prevent leaking of the surgical site, and also to monitor the progression of the other masses on his body. Thank you. Any question?
Yes, from Dr. Ben. Your epidural bupivacaine is not 0.2 mg per kg, it's 0.2 ml per kilo. For intratesticular block, also bupivacaine is 0.2 ml per kilo. So for both is 1 mg per kg. If you don't know the dosage of anesthesia, next time you can check for all the computer in UVH, there's Excel form. So you can there is also stated all the dosage and concentration for all the anesthetic and analgesic agent. Thank you. So change now 0.2 ml per kilo.